two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 103. And today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, good evening, Swapnil. How are you?
I'm good, thank you. How are you?
I'm very well, thank you.
This is our second journal club for this month. Obviously, there are some reasonably well-conducted randomized controlled trial recently published in major journals. So we are going to discuss one of them today. So the trial that we are trying to discuss today is around the timing of tracheostomy, whether we should do tracheostomy early versus late, and a trial called as SETPOINT 2 randomized controlled trial. Now, the controversy around tracheostomy is not new to intensive care, and usually often there is this dilemma around whether we should do tracheostomy after 2 weeks or before 2 weeks. There is no hard and fast clinical rules or guidelines which kind of recommend to do tracheostomy within the first week. And majority of the centers traditionally have been practicing performing the tracheostomy after 2 weeks. And that's kind of based on the previous TrackMan trial, which kind of gave us a clear signal that there is no benefit of performing tracheostomy early, that is less than 7 days. And in fact, there might be some signal of harm or complications if you do tracheostomy early. In fact, one of the interesting findings from the TrackMan trial, the patients who were enrolled in late tracheostomy, often you manage to avoid tracheostomy if you wait longer in patients who are needing tracheostomy. So I guess that's the kind of background or the context to this trial. Now, the author wanted to investigate this role of timing of tracheostomy in patients with stroke. And I guess there are several advantages to perform tracheostomy early in this subgroup of patients, predominantly with the view of reducing the sedation and analgesia, accelerated ventilator weaning, earlier mobilization and transfer to rehab. And in fact, less ICU stay, less ICU complications, and I guess even probably improved survival and functional outcomes. However, there was no particular trial which was done within the setting of stroke patients. So authors, obviously, they had previous pilot randomized controlled trial, which evaluated the potential benefits of early tracheostomy in mechanical ventilator patients with stroke. And this was a single center pilot trial, which was called a SETPOINT trial, that is stroke-related early tracheostomy versus prolonged orotracheal intubation in neurocritical care trial. And in this trial, they enrolled 60 patients with stroke who were receiving mechanical ventilation. And the patients received the tracheostomy within 3 days of intubation, or tracheostomy was performed either between 7 or 14 days if they remain intubated. And in this pilot randomized controlled trial, there was no difference between ICU length of stay, and which was the primary endpoint. Overall, sedation use, duration of mechanical ventilation, and mortality were lower in early tracheostomy. So I guess based on that pilot trial, it was quite natural to kind of explore this question further in depth with a larger sample size. So authors come up with the next randomized controlled trial, which is the SETPOINT trial, which investigated the role of tracheostomy in patients with severe ischemic or hemorrhagic stroke receiving mechanical ventilation, and whether these patients benefit from tracheostomy within 5 days of intubation. And is that a better approach, resulting in improved functional outcomes comparing to standard approach for ventilator weaning in patients with stroke? So, Dr. Checo, can you please walk us through the methodology and the results of this trial, please?
Yeah, the SETPOINT randomized controlled trial was conducted over a 5-year period in 26 neurocritical care ICUs in Germany and the US. The study population included patients on ventilation after acute ischemic stroke, intracerebral or subarachnoid hemorrhage, with a stroke-related early tracheostomy score, which is known as the SET score, of more than 10. The SET score actually includes several criteria, helps the clinician to make a judgment as to whether early tracheostomy is required, including the neurological function, the neurological lesion, whether it's involving the brain stem or the cortex, or if it's a diffuse lesion. And it also includes general organ function as one of the important criteria to decide on whether early tracheostomy is appropriate in a clinical setting. So a score of more than 10 is usually considered as an indication for an early tracheostomy, and that's what these authors used as well, a set point score of more than 10. And of course, the final call was on the clinician as to whether a tracheostomy was appropriate at that point of time. They excluded patients with a pre-morbid modified Rankin score of more than 1, which essentially meant that patients with any level of disability at baseline were excluded from the study. Those who were ventilated for more than 4 days were not included. If there was a clinical contraindication for early tracheostomy, or if there was a requirement for surgical tracheostomy, they were not included. Life expectancy of less than 3 weeks in the judgment of the clinician was also an exclusion criteria. So in the early group, tracheostomy was performed within 5 days of intubation. And in the late group, tracheostomy was performed at day 10 or later if extubation was not possible by then. Most of the patients underwent a bedside percutaneous dilational tracheostomy. Transition to open tracheostomy was allowed if clinically indicated. Ventilation, weaning, analgesia, sedation, and neuromonitoring were based on local practice, but largely based on the American Heart Association and the American Stroke Association guidelines. How did they calculate the sample size? The sample size was calculated based on the modified Rankin score, which was dichotomized as 0 to 4. 0 to 4 meant a good outcome or a successful outcome. Modified Rankin score of 5 or 6 was failure or poor outcome. The modified Rankin score 4 is moderate severe disability, unable to walk without assistance, and unable to attend to own bodily needs without assistance. That's the definition of modified Rankin score 4. 5 and 6, of course. 5 means severe disability and 6 is death. So they assumed a success rate, which is a modified Rankin score of 0 to 4, of 45% versus 30% in the late versus the early group. And based on this 15% improvement in the outcome, they calculated a sample size of 380 for a two-sided type 1 error rate of 0.05 and a power of 80%. So when you look at the baseline characteristics of these patients, they were similar in terms of the type of stroke, whether it's ischemic or subarachnoid hemorrhage or intracranial hemorrhage, was similar between the two groups. Disease-specific severity was also similar between the two groups. Most of the patients underwent percutaneous tracheostomies in both groups. And among patients who were randomized to the early tracheostomy group, 177 out of 186, which is 95.2%, actually underwent a tracheostomy at a median of 4 days after intubation. While in the late tracheostomy group, only 130 out of 194, which is 67%, underwent a tracheostomy at a median of 11 days after intubation. And of these remaining 64 patients who did not undergo tracheostomy, 43 were extubated, while 21 patients died before the timeline for a late tracheostomy. And as I mentioned, most of these patients underwent percutaneous dilational tracheostomy by the bedside, 89%, 83% in the early versus late groups. In the final analysis, 366 of the 380 patients randomized were included. 13 patients were lost to follow up, while 1 patient withdrew consent. So what were the outcomes of this study? The primary outcome was the modified Rankin score at 6 months. 0 to 4, as I mentioned, was considered a good outcome. And in the early group, 77 out of 177 43.5% had a good outcome with a modified Rankin score of 0 to 4 at 6 months, compared to 89 out of 189, which is 47.1%. So this was not a statistically significant difference. So 0 to 4 at 6 months, similar between the two groups. Secondary outcomes included the modified Rankin score of 0 to 3 at 6 months. As I mentioned, 4 is a contentious criterion because 4 means you need to depend on others for activities of daily living. So they looked at 0 to 3, which is a better outcome. Here again, 177 compared to 37 out of 189 in the late group, not statistically significant. Mortality at 6 months in the ICU and mortality due to withdrawal of life support were also similar between the two groups. Now, conventionally, when you do an early tracheostomy, you look at the time spent in ICU. And in this particular study, although it was a secondary outcome, there was no difference. 17 was the median time in ICU in the early group compared to 19 in the late group. The difference was not statistically significant. So was the time to hospital discharge and the duration of mechanical ventilation, which again you would consider as a possible likelihood of improvement with an early tracheostomy. However, this study did not find a statistically significant difference. Time to hospital discharge, median of 24 versus 26, early versus late. Duration of ventilation, 14 days versus 11 days, early versus late. And the duration of ICU stay without any sedation, without any opioids, which again is traditionally considered possible with an early tracheostomy, but this study did not show a difference. ICU stay without vasopressors was also not different between the two groups. Adverse events occurred in 47.3% in the early group versus 43.8% in the late group. Tracheostomy-related adverse events, 5% versus 3.4% early versus late. And the adverse events related to percutaneous tracheostomy included venous bleeding, 2.6, and aspiration pneumonia within 48 hours after tracheostomy, which again was a similar number. They looked at subgroup analysis in predefined subgroups of age, gender, German versus US center, high volume versus low volume center, type of stroke, and the presenting GCS. However, they did not find any significant difference in these predefined subgroups of patients. So the study concluded that among patients with severe stroke receiving mechanical ventilation, a strategy of early tracheostomy within 5 days of intubation compared to a later approach to tracheostomy at 10 days or later did not significantly improve the rate of survival without severe disability at 6 months.
Thanks, Dr. Jacker. So I guess this is a quite landmark trial in its own way because it gave us a very clear data around the overall timing of the tracheostomy. And I think after the TrackMan trial, even the TrackMan trial did have a lot of controversies around the conduct of the trial. I guess this trial also, endorsed overall recommendations or the practice that we are currently practicing around the timing of the tracheostomy. That there is no real benefit of doing the tracheostomy way too early in patients who are neurologically impaired. I guess this trial obviously looked at the certain subset of patients, which is mainly stroke patients, and quite clearly did not give us a very encouraging results of performing the tracheostomy within first 5 days. Now, when you look at the baseline table, it's quite important to look at some of the key highlights in this trial because I guess the most of the randomized control trial, even though they are negative, quote unquote, where there's no difference between the primary outcome between two groups, they give us a very significant epidemiological data. Now, I guess the key thing with this trial has looked at is a very severe neurological disability patients. The most cohort had a baseline GCS of around 6 or 7. And also the diagnosis of the stroke between two groups was not different. Obviously, the ischemic stroke dominated overall population, but the percentage of patients who had a ischemic versus hemorrhagic stroke did not differ significantly between the two groups. Also, their NIHSS score baseline was quite high. And again, that probably explains why they did not have a very good outcomes at 6 months. the encouraging results is obviously they performed the percutaneous tracheostomy in almost 80 to 90% of the patients population in both groups, which is quite reassuring because then that helps us to kind of generalize the results in our context, because majority of our ICU patients do get percutaneous tracheostomy because the surgical tracheostomy is always going to be associated with more complications and delays in performing the tracheostomies. So overall, I guess very well matched patients at the baseline. And also the authors achieved what they wanted to achieve. The timing of tracheostomy was in fact less than 5 days in the early group versus more than 10 days in the late group. Now, when you look at the overall consort diagram, what's quite interesting that they screened 4,500 patients, and out of that only 182 were randomized, and predominantly because around 1,300 patients were excluded because they did not meet the criteria of mechanical ventilation more than 4 days. And also almost 1,000 patients had a life expectancy of less than 3 weeks, which is quite significant patient population exclusion. So what does it show is probably we need to still selectively screen our patients before we make that decision of even doing a tracheostomy early or late. And I think that's the crux of the matter, because if you go and perform the tracheostomy in every single patient, that's probably not the right thing to do as well. And I think that's probably a useful thing. Now, obviously, this trial couldn't be blinded because of the nature of the intervention itself. So that kind of obviously creates some bias. Now, interestingly, the most important thing for me was how did they calculate the sample size? And the sample size was based on primary outcome of tracheostomy success, defined as a modified Rankin score of 0 to 4 after 6 months. And they were expecting the success rate of 30% in the control group versus 45% in the early tracheostomy group. So that 15% absolute risk reduction is enormous. And I think any intervention causing that much of absolute risk reduction is really, really ambitious trial. And I think that's obviously reflected in the very low sample size. And that's clearly underpowered trial to answer this question, because they're really expecting a miracle in this group of patients. Now, some people might argue that modified Rankin score of 0 to 4 is quite a broad scale. Some people might not accept modified Rankin 3 or 4 as a good outcome compared to 0, like 1 or 2. So that can be very controversial, because then that obviously includes pretty much all patients with disability except moribund patients and dead patients. And that's probably not the right thing to compare as well. So probably the trial could have been designed better way if they would have had a more tight group with regards to modified Rankin outcome scales. And I guess the other interesting finding was the 14 patients were actually not included in the final analysis. Now, whether if they would have included, the outcome would have been different. We can't tell that. So I think, again, that was quite interesting that why they did not include these patients in the trial. One of those minor limitations of the trial is they compared all types of stroke, ischemic and hemorrhagic stroke. Now, when you look at patients with subarachnoid hemorrhage versus ischemic stroke or intracranial hemorrhage patients, they would have had probably different outcomes due to the nature of the underlying pathology itself. So probably putting all these patients in one basket and comparing the intervention in all these 3 subset of patients as a one group, probably not the right thing to do as well. So probably whether there would have been a different signal in each subgroup of patients, and we don't know. And I guess one of the key outcome for me, apart from the, primary outcome, was despite performing the tracheostomy early, there was no difference in the weaning sedation regimen, overall length of ICU stay, and weaning from mechanical ventilation was not different between the two groups. So really the reason why we do early tracheostomy was really not shown any difference in two subset of patients. So they are kind of my initial thoughts when I look at this trial. What's your thoughts, Dr. Chakko?
Yes, Swapnil, what you pointed out was quite right and very relevant indeed. The outcome that they chose was the neurological outcome at 6 months. One would ask the question as to, would you really expect the neurological outcome to be different if you do an early tracheostomy? I do not know, because at least in our experience, we don't do trache aimed at improving neurological outcomes. One of the main reasons as to why we might do an early tracheostomy would be to try to take them off the ventilator as soon as possible, shorten the duration of ventilation, and shorten the duration of ICU stay, and transfer them to the ward as soon as possible, because ICU care itself can be very costly, particularly for our patients, many of whom pay on their own. So that's the reason why we might prefer early tracheostomy. But in this study, of course, although they did look at the duration of ICU stay and the duration of ventilation, as you rightly mentioned, there was no standardized weaning protocol. That is one reason why they couldn't demonstrate a difference. And second, of course, it was a secondary outcome, not the primary outcome, and it was not powered to look at that particular outcome, not powered to look at the duration of ventilation or the ICU stay. So the whole question is as to whether do you really expect the neurological outcomes to be different if you have a different sort of timeline for the tracheostomy. I think it's a very important question to answer. Perhaps the outcomes that they define in future studies should look at more realistic outcomes, including duration of ventilation and ICU stay.
Yeah, that's correct, Dr. Chacko. So I guess it's quite interesting to see how this trial will probably change the practice around the globe, because I just mentioned probably our current practices are probably already not to perform or not to rush to perform tracheostomy early. And usually we wait sometimes longer, even to 3 weeks or longer than 3 weeks to gauge what patient trajectory looks like. And if there is any significant neurological improvement, but obviously failure to wean from mechanical ventilation due to ongoing sedation requirements, then yes, we do perform tracheostomies in that setting. But usually the aim is to avoid tracheostomy if possible, especially if the neurological outcome is not going to be very good. So what's your practice in your unit?
We take a call early on, as these others did, as to whether this patient is going to require long-term ventilation or not, based on our clinical judgment. And if indeed we feel so, we tend to perform an earlier tracheostomy, although there is no absolute timeline. It all depends on the individual situation and the judgment of the ICU team and the neurosurgical team, and we come to a sort of consensus decision on the optimal timing.
Yeah, I guess, and also interesting, another factor which kind of plays a major role in, I guess, developing countries is the cost of mechanical ventilation, because in developed countries where there's a Medicare or there is some sort of government insurance which takes care of most of the expenditure, usually tend not to worry too much. But obviously every single day of mechanical ventilation in countries where patient has to pay from his or her own pocket, that obviously that extra day costs quite a lot of money. So and also, it's not just the cost of mechanical ventilation, but also it's the cost of sedation and other requirements while patient is in ICU. So I guess in that kind of setting, if the tracheostomy facilitates weaning from mechanical ventilation and helps the patient to get out of ICU early, I guess that even saves a lot of burden on the patient. It really depends on each kind of context and how that practices transpire in those settings. But suffice to say that probably doing the tracheostomy within that first 5 days is probably way too aggressive. And clearly, as this trial shown, there is no benefit to perform the tracheostomy within the first 5 days. So at least waiting for making that decision to perform the tracheostomy for first 10 days is quite important, because the tracheostomy is an intervention which can potentially be associated with other side effects or harm. Thanks, Dr. Chacko. So that's the end of our today's podcast. We'll be back within probably next few weeks with another episode on another controversy in critical care. Till then, goodbye and have a nice time.
Goodbye. Thanks, Swapnil. Thanks, everyone, for listening. Till next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.